This program is being sponsored by the Elder Action Committee and the Embracing Change Project. Embracing Change, as probably many of you know, is an educational program which has provided and continues to provide various educational programs to Ashby Village members. It grows out of member support services which provide our members with various kinds of help and support. And let me just briefly go over the components of member support. The first one is our Healthier Aging Initiative, which offers educational workshops, group fitness classes, and hiking, and an array of programming that facilitates health and well-being of our members. The Connections Team, which provides for ongoing friendly visitors to members who are isolated. The Caring Team, which offers assistance through our neighborhood groups. And the Social Care Team, made up of semi or semi-retired mental health and health professionals who are available to consult with the members who are facing serious changes to their health, their ability to live independently, and or are experiencing a change in their social support system. And this team can recommend necessary resources both within and outside the village. So that's kind of a brief summary, and I'd now like to introduce Marcia Freedman, who is the co-chair of our Elder Action Committee.
Hi, thank you very much, everybody, for coming, and we welcome you. I want to just tell you briefly a little bit about Elder Action. We are an interest group within Ashby Village. We are hoping very, very much for those of you who are coming to us from other villages that there will be elder actions all over the state of California so that we can really amplify our advocacy voice statewide. We have been working for the past year plus very hard on getting in support of Prop 15, which is a correction to the old Prop 13, which lowered all of our property taxes, but also lowered the property taxes of Disney and Intel and Chevron, et cetera. And Prop 15 would come as a corrective to that. We've also been working very hard on the issue of today's program, long-term care, which is now being talked about as long-term services and support in order to take it out of a merely medical framework. We have about 80 members of Elder Action, not all of them members of Ashby Village, some of them just volunteers and others from the community. And we're really hoping that we're going to continue to grow. We've been working on these two issues, plus voter registration and get out the vote activities for this past year plus. Now I'd like to introduce to you, and it's my great pleasure to introduce to you Jodi Reid. Jodi is the Executive Director and the Northern California organizer of CARA. CARA is the California Alliance of Retired Americans. She's been with CARA since its founding in 2003. Prior to that, she helped to found the Senior Action Network in San Francisco. She has organized around senior housing and healthcare issues for the last 40 years at the local, state, and national levels. She was part of the Citizens Advisory Committee for the Master Plan on Aging, which has just recently, I think, made 700 and some odd recommendations to the governor for his master plan on aging, and we're hoping to push it forward. One of the major ones of which, I'm happy to say, is a recommendation that California institute a universal long-term care benefit that would be based on a social insurance model, which is what we have been pushing for. It's been a real pleasure for me to get to know Jodi slightly, at least, as part of the grassroots committee of the California Alliance, Aging and Disability Alliance, and working on the issue of long-term care for all. Jodi?
Thank you. And thank you all for inviting me. I see some familiar faces, so hi to you, and I'm glad to see some new faces too. As Marcia said, the California Alliance for Retired Americans, we say CARA because it's otherwise too much to say, is at this time California's largest grassroots senior advocacy organization. And we're made up of, we have 300 affiliated organizations around the state that come from labor union retirees, senior housing resident associations, mobile home communities, other kinds of senior serving groups, democratic clubs even, any group of, that meets as an organization to further the goals of improving the quality of life can join CARA, and I hope you all consider that at some point, because when you join as an organization, any member of your organization is automatically considered a member of us and will get on our mailing list and get our materials. We do our work through a number of different networks. One is our local chapters, which we call CARA action teams. And that several of you have come to the Alameda County CARA action team. We're doing all of our meetings like this right now virtually. We also have a really big legislative committee that focuses on how do we turn some of our priority issues into legislation that can help move them forward. We either introduce our own legislation and find legislators to author, or we support existing efforts by legislators. And we do a lot of coalitional work, like Marcia said, with the California Aging and Disability Alliance and Hand in Hand, a whole bunch of groups, whether it's on housing or healthcare or long-term supports and services or transportation or climate change. We work on a lot of issues. Every year our members vote on which issues they'd like to see us prioritize. Our main office is in Oakland, which we're not going to right now, except to pick up the mail and pay bills. We're all working remotely, but I support the CARA action teams in Northern California, as well as the executive director. And then we have an LA County organizer and a Southern California organizer. And then we have kind of our office coordinator who manages database, and who, if you called the office, that's who you'd probably reach first. We represent close to 1 million members. If you add up the membership of all of our 300 plus affiliated organizations. And you can also join as an individual, but we're trying to build power, just like you're doing and trying to build elder actions all over the state. We'd like to coordinate that effort with you, because we want to build the senior movement. And the more organizations that can come together on the issues that we all agree upon, the more power we have, the louder our voice, and the more ability to make change, whether it's legislatively, electorally, administratively. There's a lot of ways to do the work that we do. So I'm happy to later, when I'm not talking, I'll put our information in the chat. So if anybody is interested in looking at our website or getting on our list, I'll put that in the chat so you'll know how to do that. So today I was asked to talk about two things. One is sort of what's happening with long-term supports and services, both from the Master Plan for Aging and beyond, and how we take what seems to be a growing consensus that what we need in California is a universal benefit for everyone, so that we can all access the care we need at home, so it can remain in our homes, in our communities, and age in place and avoid institutionalization, and kind of what I see happening next. And then the other issue that I was asked to highlight is the movement to build a single payer, or sometimes called improved Medicare for all system, where everyone is in, no one is out. The benefits are more expansive than what is currently provided through Medicare. So, how do we structure that? How do we pay for that? And how do we move that forward, both in California and nationally? So I'm going to try and do all that really quickly, and then be available to answer questions. So is that what everybody thought you were coming to?
Yes, indeed.
Yeah. Okay. So, so starting with LTSS for all. So for many, many, many years, we have struggled in California with the problem that as we age, and California has one of the fastest growing aging populations in the state, And the expectation is that by 2030, 25% of our total population will be over the age of 60. That's huge. That's 1 in 4. And our state is completely unprepared for this. And our the vision behind the governor's efforts to create this master plan for aging was to really look at the services that are currently being provided, the resources that are being spent, and develop a blueprint for the next 10 years. So the goal wasn't to like come up with a bunch of things we can do tomorrow, but that as our population ages, how do we readjust the way we spend our resources and address the growing needs of the population. And long-term supports and services has always been a really big hurdle in this effort, because as you all know, paying for services at home is pretty cost prohibitive. I mean, I'm sure if you're wealthy, you can do it, but it's super expensive and ranges between $25 an hour to $100 an hour or more. And very quickly, if you try to arrange for these services, you can run out of money pretty quickly. And what's been happening in our state for decades actually, is that people have spent down whatever money they had and eventually wound up spending it all and winding up in nursing homes, which are 3 times more expensive than care at home. But yet, because we don't have the cash on hand to pay for the care that we might need. And when I say care, I don't just mean a home care worker. When we talk about supports and services, it's everything from meals to, assistance with daily living activities like cooking and bathing and medicating, maybe getting to doctor's appointments. But it's also transportation. It's a whole host of things that help us stay in our own homes and in our communities, where most older people and people with disabilities prefer to be. And once you run out of money, the choice is an institutional or congregate setting. And eventually, because those are not cheap either, you spend so much of your money that you wind up being poor enough to qualify for Medi-Cal, who picks up the lion's share of those costs, and that's money we pay through taxes in part, and the federal government pays. And so the hole in the system is that if people who are above income for in-home supportive services, which is the home care program for people who are Medi-Cal eligible, if the upper poor and middle class folks had access to similar kind of supports and services at home at a cost that they could afford, it would avoid institutionalization, save the state money, and obviously have better outcomes for people, both because they're home in their community, but it's also ultimately a better outcome for the state in terms of resources. But making that financial shift has been very hard to do. We haven't had a good plan. We hadn't really figured out the financing for that, what options there might be, and how to move forward. And so a major part of the master plan for aging, and one of the requirements, if you will, or stipulations that the governor made, was that we have a special subcommittee just focused on long-term supports and services as a part of the stakeholder group, and that it would make recommendations. And actually, it was the first to come out with recommendations. There were other subcommittees, but that was, I think it's been highlighted as one of the most challenging parts of our aging system and services. And so a whole host of people weighed in on recommendations. And as I think, I'm not sure if it was Marcia or Julianne who said, out of this master plan for aging process, 743 recommendations were sent to the governor. He and his staff are reviewing them, and they will come out with their final master plan on aging that hopefully will include a lot of the recommendations that we all participated in making, but we don't know that. And so we've been working with the administration to try and make sure that they capture the highlights of that work. And December is when the governor is supposed to issue his final report. But even if he doesn't agree to all the recommendations we make, the folks who are on the advisory committee and all of the groups that participated in informing it are committed to working to move the issues that rose to the top forward. And like I said, long-term supports and services, otherwise known as LTSS for all, is one of those issues that rose to the top. But here's the challenge. A couple of years ago, through the California Aging and Disability Alliance, which we're a part of and many of you are part of, we've introduced a bill, SB 512, that was authored by Senator Pan, who's from the Sacramento area. And this bill set as kind of a goal the creation of a universal benefit for seniors and people with disabilities, but with a first step being doing an actuarial study to determine over the next 5 years, 10 years, 15, 20, how many people could in California could potentially be eligible for an LTSS benefit. What is the cost of that benefit? You know, usually people get assessed on how much services they might need, and they're given a certain number of hours per day or per week. How much per hour or per day would be an average benefit that people would take advantage of, and how much would that cost? And then the big item, how do we pay for it? And so Milliman, which is this actuarial group, and you know, it's like some of those studies are like full of numbers and accounting stuff. That's not my my area of expertise, but what I got out of that and what we learned from the study, which was just completed this summer, is that they used a model that was developed in the state of Washington to kind of base their study on. And there's some real problems with that model. Number one, it eliminates anybody who is under 18 who has a disability from being included in any benefit that is created. And it also excludes any current seniors, because the issue is that this is kind of a, you have to invest in it. It was modeled on a payroll tax. And so people who are retired aren't paying into a payroll tax. So you're not contributing to the fund. And in order to build up a fund so that people can start accessing a benefit, there has to be some money in there. And so current retirees won't have anything invested in the fund, so they would be not included in the formation of this new benefit. We have a real problem with that. And a payroll tax isn't the only way to fund a program like this. So the big challenge right now that many of the groups are talking about is that now that we have the study, how do we move the state forward to creating this universal benefit for everyone, and who will be included in it? Because if we need to build political support for this benefit, which we obviously will, because we're going to need to talk our legislators and the governor into supporting a program like this, and however we finance it, supporting the financing, we're going to need all of us talking to our own elected officials and trying to move this forward. And there is a big concern that if current seniors aren't in the mix, are they going to be as willing to fight for this? Because they need some of these services now. So one of the questions is there a way to create a startup fund, you know, with some cash that would be available so that people who currently need an LTSS benefit could access it while we build up the fund for future beneficiaries, for lack of a better word. And that's a big conversation that's happening amongst members of the master plan stakeholders group, around the California Aging and Disability Alliance, everybody who's been interested in this, the financing and how we do a progressive financing structure, so that, and then what the benefit would be. Would it be, you know, a max of $100 a day per person, or $50 a day per person to start? How do we set that up? So I've got a lot of information now from the study to build from, but there's a lot of work and a lot of conversation that's happening now about what the next step is. What do we propose? And given that California, as every state, is facing huge challenges financially because of the pandemic, how do we, what can we move forward in this environment? Hopefully that's not going to last forever, and California will start rebuilding its budget and its resources, which we fortunately had quite a bit in the rainy day fund from previous governors that helped us avoid some very severe cuts this year due to the pandemic and the recession that followed. But we've used a lot of that money to keep things afloat, and so we have to rebuild some of that. And there's a lot of ideas about more progressive sources of funding, a wealth tax that could maybe at least establish this benefit so that current folks in need of it could access it. But we haven't worked out all those details, and so that's where we're at. I don't think there's questions amongst the advocacy community, amongst the senior community, even amongst the cabinet members and the administration and the legislature, that we need to move to this, that the fact that our system only supports an LTSS benefit if you're very low income and Medi-Cal eligible, is really a mistake. And it is costing the state money. It is costing people's lives. It's forced people unnecessarily in institutions. And during this pandemic, these very institutions are the place where people are dying, because there's a whole nother set of issues and concerns around nursing homes and RCFEs, residential care facilities for the elderly, that also need to be addressed. And that's a model. The model of these nursing homes and large congregate care settings are kind of a thing of the past as well. That is not the way in the future. If we're going to build more congregate care facilities for people who need more care, you know, more sort of 24-hour supervision, these big warehouses have proven to be not effective in providing the kind of care that people who wind up in those facilities deserve. So that's a whole nother effort around nursing home reform that is also simultaneously happening. But even as we reform that, the cost per day is up to $400 now. And more, higher, depending on the facility, that the state through Medi-Cal is primarily paying, which with our tax dollars. The federal government pays a portion of that too, but it's public dollars that we pay for out of taxes, whether they're state income taxes or federal taxes. And it's not a good use of money. So I think there's agreement on where we need to go. I think the next step is going to be how we get there. And the more we can come up with a proposal and unify ourselves around it, so that we all are asking for the same thing, not a bunch of separate efforts from this group or that group, but the idea is to try and come up with a proposal, share it with our colleagues, with our organizational partners, with whomever is interested, and all sign on so that we can speak with one voice to move this forward. I think that's what's going to happen. I've always said, since we do a lot of legislative work, that the easiest way to assure that nothing happens is to have a bunch of advocates all asking for the same thing, but with different ideas. Because the legislators take advantage of the fact that we're not unified. And, you know, I don't want to say yes to this bill and no to this bill because I'm going to piss somebody off. And when you all have your act together, and can agree on what you want, come back to us, because the easiest thing for the legislator to do is nothing. That's their favorite thing to do, because it doesn't make anybody mad, including the nursing home industry and some of the people who are profiting off the system, the broken system that we currently have. So I feel like our most important work is making sure we have representatives at the table as we try and debate where we go next and how we go, and that we all can unify around whatever that proposal is. And we don't have it yet, but we are working to try and develop a legislative vehicle to introduce into the next session, which starts in January. So I think that is kind of a summary of where we are with LTSS. So I think I'm going to move to, and I'm happy to answer questions. I think you wanted to do that at the end. So write down your question if you have one about this. And I'm going to shift to Medicare for All or single payer, because they kind of relate in some ways, although the path forward to each of these is slightly different. So the California Alliance for Retired Americans, since our formation, has had moving towards an improved Medicare for All system as a top priority since the day we started. It was voted on at our founding convention, and we continue to work in coalition with other organizations. There's a coalition in California called Healthy California Now. One of CARA's board members actually serves as the chair of that group. And it includes the nurses and many other unions, but the California Nurses Association, a bunch of other organizations that have healthcare for all as a priority. And there's really two tracks to work on here. First of all, Medicare for All, I think, is a mistake to call it that, because as we all know, Medicare is not perfect. And Medicare, though you do get hospitalization covered, you have to buy all these supplemental plans or be in an HMO like Kaiser, for example, which takes what's called a capitated amount, a set amount of money that Medicare on average spends on a beneficiary, and gives it to Kaiser in addition to your payment or your employer's payment if you get that benefit as a retiree benefit. And then Kaiser, for example, is expected to offer all of the benefits that Medicare provides, as well as the supplemental benefits like office visits, prescription drugs, specialty care, et cetera, in addition. So when you have to buy a supplemental plan or one of these Medicare Advantage plans, the idea is bringing in the hospital side of Medicare, which you've paid for all your working life, and which you still make a payment towards out of your Social Security. And then sometimes you have to pay an additional amount, which is administered through a private healthcare organization or insurance company, to pay for those things that aren't covered. And Medicare, unfortunately, unlike Medi-Cal, Medicare does not cover a lot of body parts: eyes, ears, teeth, feet. It doesn't cover some durable medical equipment. It doesn't cover some certain kinds of outpatient specialized care. It doesn't cover prescription drugs unless you buy another plan, Part D plan, that covers prescription drugs. But most importantly, it doesn't cover long-term supports and services, except the first 100 days after a hospitalization. So if you were hospitalized and you need rehab or physical therapy or some kind of ongoing care, it covers out of your regular Medicare the first 100 days. But after that, if you need to continue that kind of care, you're out of luck. And although you can use some of those 100 days towards home-based care, that's really tricky and complicated. And really, it's much more geared towards like a rehab center or skilled nursing facility for that extended care. And so when we say Medicare for All, the Medicare system is far from what we need. So we always say, if we're going to use that terminology, an improved Medicare for all that would include all of those services that are currently not covered by Medicare. Other people call it single payer, which really refers to the way bills get paid. So instead of there being, I'm going to turn 65 in February. So I'll be on Medicare, which I've been waiting for. But I know you all experience this. I don't know how you could stand it. Every day I get something in the mail saying, join this plan, buy this supplemental. I'm keeping them because at the end, I'm going to make them into some kind of collage that I can set on fire. But literally every day I get something from somebody that I've never heard of who wants me to buy their supplemental insurance. And so, I feel like one of the big problems in our healthcare system overall is the fact that there's so many of these plans, and every one of them has different things that they cover. Different things that are on their formulary. Certainly with prescription drugs, if that's a part of the plan you're buying, they have a set formulary. These are the drugs we will cover. And if you get prescribed one of these other drugs, a specialty drug or whatever, you pay out of pocket if it's not on that list. And so people have this vision that once you're on Medicare, it covers everything and that you don't have to pay anymore. Well, that is such a misnomer, because we all know, yes, you have to pay. There's premiums, there's out-of-pocket costs, and then there's, of course, things that are not covered. A single payer system would eliminate all these different insurance companies and PPOs and HMOs. And there would be one single place where providers send their invoices for the services that they provide to you, whether it's a doctor or a nurse practitioner or a therapist or a podiatrist or whatever. Everyone would send their bill to one place. There would be no insurance companies involved, so they don't have to market and send me all these glossy packages that they've been sending me. They don't have to pay their CEOs tens of thousands of millions of dollars. They don't have to pay for advertising and the administrative costs, which can run anywhere between 15 and 30 cents for every dollar you spend. That's not going to healthcare. And these companies, they don't provide healthcare. They're not healthcare providers. They're middlemen who are their major function is to figure out how to spend the least amount of money on your care, because the less they spend, the more they make, and they are beholden to their stockbrokers and their stockholders. This is a broken system, and it's a waste of money. We spend almost enough money in California, which is the 5th largest economy, through public dollars that go to Medi-Cal, special programs that we've passed in California, and people who are covered by the state of California, California state employees, prisoners in the Department of Corrections, and Medi-Cal recipients. We're already spending in California enough money to cover everybody, including the millions who are uncovered. But with all this waste, these folks don't get covered. And even those of us who have insurance are often underinsured. And because of COVID, and because our system is really designed around employer-based insurance coverage, what we found, what we saw, what we're experiencing is all the people who got laid off from work because of COVID lost their health insurance. So we already had a problem of millions of people not having access to coverage, and we made that problem 10 times worse by having a system that marries your ability to get healthcare insurance with employment, instead of it being a right that everybody has access to. So what we're trying to create is a system that allows us to negotiate for the services that are provider. So that in Marin County today, if you want to get a hip replacement, the average cost of going and getting a hip replacement and the follow-up care that you need is $75,000. If you go to Santa Clara County, that same procedure is about $55,000. Why? I mean, is it $20,000 more expensive to do surgery in Marin than it is in Santa Clara? We don't have a global budgeting system that we've negotiated. So it's really whatever the market will bear and what they can get away with. And that cannot continue. Medicare does set rates for procedures. And though some doctors think they may be too low, what it does offer is that everybody knows if you're going to do, angioplasty in California, this is how much you're going to be reimbursed if Medicare pays for that. And it's called, so it gives providers and hospitals and everyone and you information about what to expect in terms of costs. So what we're shooting for is a system, a single payer system that has a standard package of benefits that is comprehensive, along with negotiated rates, including negotiating for pharmaceutical costs, which currently we're not allowed to do. So that we can have a sense of how many people, what it's going to cost, and how are we going to pay for it. In California, there's an effort through a coalition called Healthy California Now to try and have California set the tone for the rest of the nation. We have we have two presidential candidates, one who actually will never do this, and the other who says he doesn't support Medicare for all. He supports the ACA and possibly expanding the ACA, but he's not ready to support Medicare for all. He thinks the ACA is just fine the way it is, with maybe a public option, which I can answer questions about what that is, but that is not something we support. But in the difference between those two national candidates is that in the ACA, there is a provision that many of us fought for that's called a state innovation benefit, where if a state wants to try to develop a healthcare plan that goes beyond what the ACA offers and requires, they can apply to the federal government to get waivers to bring the dollars that the federal government spends on behalf of California residents and bring that into our state in order to build the pot that will allow us to cover everyone. They could also do that nationally, but I don't see this happening nationally. But what I do see, depending on who wins in November, is the possibility that California, if we can talk our governor and our legislature into it, could be the first state to request the consideration of a waiver so that we can try a system like this, show the rest of our country how it works, how much money we can save, how much better the benefits can be, and how we can cover everybody who lives in this state. Then will be, and because California is so big, it's the 5th largest economy, it's bigger than Canada, our neighbor who has a program like this, then we can lead the country, and hopefully the rest of the country will soon follow when they see what we've been able to accomplish in California. That is how Canada did it. When they first started thinking about creating a universal single payer program, Ontario was the first, no, actually it wasn't, it was Winnipeg was the first province, they don't have states, they have provinces, who developed this plan, and they showed such great outcomes and such cost savings that soon British Columbia came next, and Ontario, and pretty soon the whole government decided we're going to do this for the nation and not just province by province, because the more people in, the more the program is resourced and the better it functions. So in California, we're working to try and get the governor through his Healthy California Commission, which he established, to look at financing options for a system, a single financing system. They've been suspended temporarily because of COVID and then because of the fires, but they are going to be reconvening in February, and we're trying to implement and influence that, and from that hopefully take the next step, and depending on who gets elected, that next step will be much more clear if we have a more favorable administration who will allow us to try and innovate in California. It's a lot of work. We're going to have to be convincing not only our state legislators but our congressional delegation as well. But we have the research, we have the facts, we have the numbers, we have the experience of countries all over the world who have a system like this. They're all a little different. No two are the same, but every industrialized country in the world except us doesn't cover everyone and has some sort of universal system for their residents. Some are hybrids, the people who provide service are paid for by the government. Others, they're private physicians and providers who are reimbursed by the government, but they're not employees of the government. That's the employees of the government is the British model. But there's a lot of ways to do this, and everyone has shown they have better outcomes. People live longer, infant mortality is less, it costs the government less than what they're currently paying, and the benefits are better. And in terms of LTSS, which is where we started, this would be part of our proposal is that LTSS would become one of the benefits that we add as a standard benefit package. And it's another way to get that instead of what we're currently doing, which is trying to win that benefit as a standalone. If we had a single payer system, we would take that benefit and incorporate it into the benefits in addition to, like I said, dental and vision and all the other benefits that are currently not part of our system. So Healthy California Now is the organization in California that's working to figure out how to move California forward and influencing the governor and our legislature, but also coordinating with our congressional delegation to be primed that if the election, once the election happens, we could move our efforts in California forward. So I think I'm going to stop there. That was my 40 minutes and take questions.
Erik, are you there?
Yeah, was just unmuting myself. So we have, Lisa made a comment that said Medicare may pay up to 100 days in a skilled nursing facility, but that is not always the case. It's much more likely that a person would get 21 days in a skilled nursing facility or rehab.
Yeah, and it's actually 100 days in a calendar year. I dealt with this with my father because he was in and out of the hospital, and I had to keep fighting for him to get more days in a rehab facility. And you can do it, but you're right. It says in the law it's 100 days, and it doesn't say, you know, you can only get 21 at a time, but they're very nervous about spending all of those days at once because what if something else happens later in the year? And it's really 100 days post-acute throughout a calendar year or benefit year. So you're right, it's really hard to get more than 21 days at a time, though it's not impossible.
Cynthia asks, so assessment of our needs was without telling us how our answers affected our benefits. Is there a way that we can help each other by sharing our experiences who are applying for benefits so we can learn how to be interviewed for services? And what are the hours of evaluation?
Well, for IHSS now, which you have to be Medi-Cal eligible for, and I'm pretty sure they'll use this model once we expand to a more universal LTSS benefit. Usually it starts by a social worker coming and doing an assessment of your situation. You know, how much, you know, they look at what your, they have a list of what are called daily living activities or daily activities of living. I forget which order that is. And it's everything from like showering and bathing to medicating to cooking and cleaning. I mean, there's a list of, I think there's like 30 or 40. And they interview you. And the more of those that are checked off, the more likely you are to get more hours assigned to you that you need. And, you know, but there are definitely, I think one of the things we're going to need to figure out as we expand this benefit is we need to increase the workforce is a huge issue. huge issue in the area of aging in general. We, you know, there's a paid workforce for in IHSS through, because it's a Medi-Cal benefit, and so they are paid by their counties through what's called public authorities, and they don't get paid enough. And this is tough work we're talking about. This is direct hands-on personal care, and it's, especially during COVID, it's been really challenging, and there hasn't been enough PPE for all the workers. And this is for the publicly paid workforce. But then there's most of home care is provided through either privately arranged paid domestic workers or home care workers, but even more family members. So when we think about the impact that family caregivers have, it's huge. You know, it means people, often women, are taking care of their family members and in an unpaid way, as well as often having to give up paid work as the needs of their family member increase. And so I think one of the things that we're going to need to learn and do is, one, we have to really recruit a much bigger, more robust workforce. We need to pay livable salaries for people to do this work. We need to, if family members are going to continue to provide care for their loved ones, we have to provide support, training, and respite for those folks. There's a lot to consider as we develop this benefit, and learning how to advocate for yourself to get the most benefit that you can is one of the things we're also going to have to learn, as well as how to help you actually become the employer. So you get to participate in picking the worker in the IHSS system, but how do you do that? I mean, how do you assess the right person for you to provide the care that's culturally competent? You know, if you speak another language, to make sure they speak that language, someone you're comfortable with. There's a lot to this. And so the whole system needs to be enhanced, you know, from the consumer perspective, the provider perspective, the employer perspective, the workforce perspective. And that needs to be part of whatever we propose, that we build on the systems that are in place that do work and fix the ones that don't.
Cynthia follows up that question with another one that said, a big waste is that we in our insurance pay $32 an hour, but the caregiver gets only $16 per hour. If we take the caregiver privately, we'd pay a $10,000 finder's fee to the agency. Can legislation place some reasonable limits on a finder's fee?
If we had a universal benefit that was administered publicly, we wouldn't have that cost. We wouldn't have to pay it at all, nor would we have to pay for the administrative costs of the companies that offer potential caregivers, like, you know, the home care agencies that you have to pay. So you're not only paying them a finder's fee, but you're paying them for administering and paying the program, and they get a good chunk of the money that should go directly into the pockets of the worker. In a publicly run system, you wouldn't have those costs. So that's another reason why we want to move towards a social insurance model that eliminates some of that overhead need, so that we wouldn't have to pay out and waste that money that's not going to direct care. The same is true for a single payer system, getting rid of the insurance companies that are the middlemen between you and your provider, taking out the need to pay them for their administrative costs and their profits and their marketing would mean all those dollars could go directly toward care.
Carolyn made a comment that said the single payer system, why don't we model it after what she has from Los Angeles Unified School District that she retired from, where the providers send bills to only one place?
Well, that's the idea. That is the idea.
And then Susan writes, I agree that we need a better system for now. You know, high cap, health insurance, counseling, and advocacy programs that are unbiased resource group for trained volunteers that help people make sense of their own Medicare options for doctors and procedures, including the best drug plan that will help cover their medications.
HICAP is a huge resource. I hope you all know about it. Every county has a health insurance counseling and advocacy program. That's what HICAP stands for. And every county has their own. And they have both paid staff and then a lot of trained volunteers who, if you are having trouble, like, getting all these brochures like I'm getting and deciding which one's the best one for you, given your health situation, if you have, existing conditions that you're trying to manage, etc., they can really help you look at the options, they can look at the services that are covered, the prescriptions that are covered, and help advise you to look to see if the doctor you're currently seeing is in the network. That's another huge issue. You don't get a choice of providers when you're in a plan. You get the providers that are part of that network. And if you're seeing a doctor before you become Medicare eligible and you want to stay with that doctor, then you need to pick a plan where that doctor is in that network. Otherwise, you will not be able to go see them. So HICAP has all this information and knows how to help ask the questions you need asked so that you can make the best choices. And also, if you're having problems where you get billed a surprise bill because something wasn't covered that you thought was covered, they can also help you and advocate for you and with you to negotiate some of those uncovered expenses if there's a way to get them covered. So I urge everybody to get the number of your local HICAP because you never know when that might come in handy.
Mm-hmm. Great, thank you. Cynthia said, the home care industry seems to be a part of the race to the bottom towards such low wages that caregivers cannot make a living wage and likely rely on government assistance of some kind. How can we make this work for everyone involved?
Well, I think we have to advocate for living wages for these folks. Like I said, they're doing, incredibly hard work. And there's a set rate that the state requires for in-home supportive care, which is the one form of home care that's currently funded for Medi-Cal beneficiaries. The state sets a hourly wage, which is low. It's not even at minimum wage yet. But counties can choose to supplement that so that they get to minimum or above. So like in the county where I live in San Francisco, the supervisors have voted to supplement that base rate that the state sets they're the highest paid home care workers in the state. And saying that does not say that they're getting paid a living wage, but they're getting paid for their work $5 or $6 an hour more than someone in San Joaquin County or Humboldt County, et cetera. So we have to establish a living wage. If we want to recruit the number of home care workers we're going to need if we expand this benefit, we absolutely have to fight, not just for us to get the benefit, but incorporated into our financial analysis has to be what is a reasonable living wage for the people who are doing the work. So we can't nickel and dime it on the provider end so that we get another hour of service. We have to fight for a living wage for those workers because that's going to benefit us in the end, because we'll get a better worker who will stick with the job because they're getting paid an amount that they can live on. And the turnover won't be as high as it is right now. So we will get a better caregiver and get better care.
Great. And Jess asks, do we have any ideas about how many Californians are paying for their own long-term care insurance in dealing with high premiums?
It's I don't know the number exactly. There was a benefit that CalPERS, which is where the retirement fund for public employees, had offered, for example, to their members, and it was super expensive. And it didn't cover very much care. And it wound up going belly up because there wasn't enough money in the fund to cover the benefits that people were trying to access having bought that insurance. And it's super expensive insurance, and it wasn't, it takes a while to build up the fund. And so there are very few people who have the advantage of a long-term care insurance policy, and they're super expensive for this reason, because the care is expensive and they haven't, the plans haven't been around long enough to build up any sort of pot to pull from. So they're charging current people who are paying premiums an enormous amount of money for a very minimal benefit. So a lot of people who thought that would be a good idea have stopped paying into it because they're not getting very much out of it. And the less people in, the more expensive it is for the people who are still paying for it. So it has turned out to be a failed experiment.
Great, thank you. Diane made a comment. I got my father through 10 years of intensive out-of-home nursing care in the state of Arizona by working with a combination of the Veterans Administration through their disability benefits, AARP's United Healthcare Supplement to Medicare, Medicare itself, and personal savings for hearing, vision, and specialized skin care. And that worked until about 2 years before his death when we had to apply for Medicaid. He lived to be 98 and received good enough care near extended family with monthly visits from me. It was exhausting, but I learned to appreciate the Veterans Administration for medications. You certainly can't beat their price, as well as legal elder care advocates to set up a specialized trust to bring his income down to qualify for Medicaid. No one will be around to do all of this for me, but of course it always helps to have a family member who understands the individual's personality and the needs of that specific senior.
Well, that tells the whole story right there. I mean, just the perseverance and dedication that you showed your father to pull all these programs together and take advantage of the VA, which has pretty good benefits, and these other programs. It's exhausting and it's unnecessary. It shouldn't be so hard to provide care for yourself and your family. There should be a standard set of benefits that we all know and that we contribute to, the government contributes to, and then there's a single entry where you access those benefits. The fact that we have to spend so much time trying to piece stuff, spend down our savings so that we become Medi-Cal eligible, so that we have nothing else to fall back on for ourselves or what we had hoped to give to our family, it's ridiculous. It's just a crazy system. And that description shows you exactly how crazy it is. And during a time when you have a family member who is aging or you're aging and you want to spend your last years enjoying your life, having your family around you, not feeling completely stressed out. I mean, I have to say, I had a similar experience. I said with my father, he lived in Chicago. My brother was there, but I'm here. And I was running to Chicago like every 3 months, dealing with one crisis after another. It was exhausting, depressing. And I had to spend so much time dealing with administrations and bureaucracies, and not with my dad, who I wanted to spend the last years of his life with him, not having to worry about it. And that is just, unfortunately, the experience of so many people.
Great, thank you. Kathy would like to know, can CARA count on AARP to support its efforts for a single payer system in California if
Absolutely
the state
not.
gets a waiver to try it?
Absolutely not.
Okay.
AARP does a lot of really great work. And so this is not a rag on AARP. And on some issues, we do a lot together. LTSS is one of them. But on healthcare insurance and single payer in general, AARP owns the largest insurance company that provides Medicare supplemental insurance, called United Healthcare. And that is how they make their money. That's why they're so rich. It's not from your $5 membership. It's from selling supplemental insurance. And that's their business model. And so anything that has to do with changing, moving away from an insurance-based healthcare system, which is what a single payer system is something they will fight to the death on, because that's how they exist. So they will continually fight to ensure that there is always an insurance model of healthcare. So on that issue, I don't think we'll ever agree. But on other things like the need to create a universal LTSS benefit, they will agree. Now, of course, they're going to want to get paid more money in premiums and include that in their insurance. If we are able to do, that would be the model that they would use, but they don't disagree that we need that. How we go about it might be really different.
Great. Sue had a comment for IHSS. Some folks not on Medi-Cal, but low income might be eligible with paying some of the costs, called share of cost each month.
Yes, that's an additional program that we fought for to raise slightly the income eligibility to get IHSS, but then you pay a share of that to get the benefit. So that it is not expansive, that additional window, but it does exist. So if you are what I consider upper poor, you should check in with your local Department of Aging or your public authority. That is the entity in each county that oversees IHSS, to see what the threshold is for your county income-wise and how much you would have to pay towards the benefit, because we have fought to expand that, but it's still very limited, but it's better than it was.
Mm-hmm. Great. Sally had asked, in the modeling done with the WA model, what would the payroll tax have to be to fund the LTSS program in the future?
Oh, it depends on what the benefit will be. So if we started small with like an average daily maximum of $100, which might be 4 hours or something, I don't know. I mean, I'm kind of making this up, but I'm just to use easier math for my head. If the benefit per person that was allowable was up to $100, and we said the average cost per hour was $25, that would give you 4 hours a day of care at that amount. Then that would require us having, and we expected 1,000 people would be eligible for that benefit. So, then you multiply 1,000 by 100 by however many days you get that benefit, and you come up with a number of how much you have to have in the pot to pay for that. So the payroll tax would, if we use that model for financing this benefit, which is currently what they're looking at, would depend on what benefit level we offer. What's the maximum benefit per day, and what's the maximum days per week that benefit would be offered. And that would tell us how much money we need, and then working backwards, how much, it's like a 0.1 to 5% addition to the payroll tax, which you're already paying when you're working. But it does raise the whole issue. If you're no longer working, so you don't pay payroll tax, what do you get? And how is that funded? So there's a lot of questions in that, so I don't have a definite answer, but you could go to, I'm trying to think where that Milliman study, it's somewhere available online. And it might be through the CADA website, the California Aging and Disability Alliance. And you could look for the Milliman study, and they do the modeling. So they give you a lot of scenarios, and you can look at what the payroll tax would be if you did this, or if you did this. So they tried to model it out a little bit just so we could be thinking about it, but I don't have those numbers in my head.
Mm-hmm. Great. Lisa asked, it's my understanding that only Genworth is continuing to provide long-term care insurance policies in this state. Is that still true?
That could be, I don't know.
Yeah. Cynthia said, I have the CalPERS long-term care insurance and have just begun to receive benefits. So that's
Good.
great. That's great.
Good for you. I'm glad somebody's getting benefits from that insurance.
And Diane wrote, I disagree with the criticism of private long-term care insurance. I brought it because I had no option. The company is good, the costs are moderate, but I think it'll really begin to pay off when I need in-home care.
Okay.
Sue asks, do long-term care companies exclude people with pre-existing conditions, like if you had cancer or other long-term diseases?
I don't think so. But again, I'm not sure. I mean, theoretically, right now in our country, you're not allowed through the ACA. I mean, that didn't necessarily apply to long-term care insurance, but it stipulates that you cannot deny anyone access to coverage because of pre-existing conditions. That could change if the Supreme Court rules on it, or if we, depending on who we elect as president. But at the moment, that part of the ACA stands. You cannot deny coverage. And I think that's for any insurance product, including long-term care insurance.
Okay. Laura writes and asks, what do other countries do? Aren't there some models that we can learn from? And then Lisa commented on that, saying other countries seem to embrace more of a quality of life and not a quantity of life model.
Exactly. Every country is slightly different, as I said, but I have a friend who's from Canada, and her two parents are still living in Toronto, and they're both in their 90s. And they were living at home, and they got, for many, many years, they had a daily home care provider for many hours during the day to help them get their meals ready, bathe them, do their medications if they needed assistance. And then they were on their own at night, so they had no one there at night. And that was all paid for as part of their health insurance. They paid nothing out of pocket for that care. As they've gotten older, and I think one of her parents fell, they decided to move into an assisted living environment. And so they are paying for their housing, but their health insurance, their housing costs do not include care. That care is still paid for by the country of Canada and their healthcare system. So all they had to worry about was paying the rent on the housing, not on the care. But they're able to get more round-the-clock care there because they're in a more congregate setting and they have staff on site that service many people. But that's still paid for through their health care coverage by the country of Canada. So housing and care were separated so that they could afford to move and they could still get access to that care. We don't have that at all here. I mean, you can move into assisted living and pay a lot of money to get care, as you know, and the cost of your housing and additional health care goes up as you move into different levels of care within some of these assisted living facilities, but they're not, it's not paid for by your insurance. You have to pay for that, for the ability to live in a place that has that kind of level of care, in addition to paying for your regular health care coverage.
Thank you, Jodi. Susan asks, I'm not sure if it's still available, but I bought an insurance policy that can also be used for in-home care once I reach the point of needing help with 3 ADLs, activities of daily living. It was an expensive lump sum up front, but way less than a year of any kind of care and beneficiaries inherent any part of the amount not used for that. Are those kinds of policies still available?
They are, but they get, depending on your age and when you start paying into those policies, the price changes. So if you don't start buying that until you're, over 65, the cost is quite high because the possibility of you sooner rather than later needing to access that benefit is greater. Whereas if you started by paying for that insurance when you were 30, you would have invested in it a lot longer, and so the monthly premium would be less. So I think some of those products are available, but the cost really depends on when you start investing into that insurance.
Mhm. Great. And Judith writes, I would just like to point out that the original Medicare permits you to choose any doctor who obviously accepts Medicare, but you do have to get a Medigap policy to cover what the original Medicare does not. And if Medicare does not cover an expense, the Medigap policy will not either. And then Evie asks, do you know what the connection between AARP and the government is? The legislator seems to feel they represent seniors in the country. I remember that they were working on Medicare changes on the government level when the donut hole for prescriptions were approved. It seems like a lobby group.
Well, they do have a very powerful lobby group. Are you kidding? They represent, they consider anybody who pays a fee to whether an AARP card, and it's a great card to have for a very little amount of money, because you can get discounts at stores, you can get discounts on eyeglasses, you can get discounts on all kinds of things. Plus they have some great programs like older drivers programs and all kinds of stuff. So that $10 a year that you spend is well worth it for the discounts that you can get. But anybody who buys that is considered a member. And so millions of people are members of AARP, and they say they're advocating on their behalf. The problem is that they often don't ask those members what issues they want them to advocate on their behalf for. And like I said, they have some other conflicting priorities sometimes. But you know, AARP, and I remember this because I was working, I was just starting my job with the California Alliance for Retired Americans when Part D was being negotiated. And there was an acceptance at the congressional level and at the, the national level that prescription drugs were too expensive and that many seniors were unable to afford the drugs they needed to manage chronic illnesses or deal with a temporary problem. And so we needed to do something about that because they weren't covered by your Medicare or your supplemental insurance at that time. And so they created Medicare Part D, and if you remember, passed it in the middle of the night, like at 3 in the morning. And the pharmaceutical industry basically wrote the law, and AARP lobbied for its passage and now sells Part D plans in addition to their supplemental insurance plans. And when we tried to meet with Senator Feinstein to say, it was a crazy way they created this benefit, and it's how the donut hole got created, it's almost like that, what a crazy model to use. But they had this much money that the government was going to be willing to spend on a Medicare benefit, on a drug benefit. And then they worked backwards and said, so if we are ultimately only going to spend this much money, how much of a benefit can we provide? And they came up short. So that's how they created this donut hole, so that once you hit the certain amount, you no longer had the benefit until you spent like $5,000, and then you started getting the benefit again. I mean, mathematically and just on a personal level, the most complicated, ridiculous benefit I've ever heard of. So we went to Dianne Feinstein's office to say, this isn't the way to create a prescription drug benefit. We need something that's much more user-friendly, that's a standard benefit that everybody has, and that has a formulary, so that the top 100 prescriptions in the country are part of that formulary, not some insurance companies cover these and some insurance companies cover these. And we tried really hard to talk her out of supporting it. She wound up voting for it, and what she said was, AARP supports it, so it must be good. Which is the problem, I think, with making the assumption that AARP is always representing our best interests. Because sometimes they do, And so again, I'm not saying they're, you know, they're always on the wrong side, but on healthcare issues, I would do my homework about what they're advocating for and who is it really benefiting. They were part of the reason we got that benefit, along with the pharmaceutical industry. And it was a poorly thought out benefit. It wasn't what most people were advocating for. And they got a lot of they got members on both sides of the aisle to support it. And then could, you know, chalk it off their list, and they didn't have to do anything after that. And it was a real mistake.
Great, thank you, Jodi. We have one final question. Kathy would like to know, how can we get updated on the January 2021 proposal that you talked about earlier? Is there a website where the results will be posted or summarized?
You mean in terms of like legislation that we move forward this year? Is that what you're referring to?
I think so. Kathy didn't give me any more information than what I read, so we'll say yes to that unless Kathy would like to chime in.
Well, certainly you can stay connected to us. We send out an alert every couple of weeks that focuses on kind of the top things happening at that moment. And if there is an action that needs to be taken, call this person, email this person, in those days when we used to be able to come together. Those days will return at some point, you know, come to an event. We announce all of those. So you can get on our email alert list by, you know, signing up. And we'll be updating our own members about that. And certainly you can be part of that update. I'm sure many of the other members of the California Aging and Disability Alliance will also have a mechanism to inform people in their own organizations. So between us and Elder Action and Hand in Hand, you know, we're all going to be talking about this, but I invite you all to consider, you know, signing up to be part of our organization so that you can get on our alerts. We work on a lot of other issues besides LTSS and single payer. So, you know, if you're interested in other things like climate change or pedestrian safety or public transit or affordable housing, you know, you will also get information about some of those things as well. I'm going to put my email address in the chat so that you can contact me directly, and I can sign you up. And I'm also going to give you our website so that if you want to just check us out and see what else we're up to, you can do that too. Sorry, I can't type as fast as I can talk.
Well, while you're typing, all right. While you're typing, let me thank you very, very much. I feel so much more well-informed now than before you started speaking. I really learned a lot, and I think others have as well. I just wanted to let people know before we all sign off that if you're interested in information about Elder Action, our email address is elderactionnow, lowercase, one word, @gmail.com. You can just write to that email address and we'll send you information about Elder Action happily and whatever else is going on, particularly about the long-term care initiative. So with that, I think we are signing off. Again, thank you, Jodi. That was very informative.
And I would like to thank you as well, Jodi. That was a terrific presentation.
Thank you, Jodi.
We learned a lot.
You're welcome. You're welcome. Good to see you all.
Yeah, thanks everyone for coming.
Thank you.
Bye.
Bye.
Bye.